last year, and he was doing the RN to BSN, and he followed me for a semester. And when we were doing pump things, he's like, when we left a room, he said, it's like they've got a loaded gun. They can just keep adding more insulin. And that's why you want somebody who cognitively is intact. The pump has some safety features in it, but you don't want somebody who can't remember if they bolused or not to be to have that pump in their hand. So they sign a contract with us. So any patient with a pump should never get sub-Q insulin. They already have insulin on board. You're going to cause lots of trouble. That's why we want to mark these people pretty clearly that they have a pump. You're never going to remove the pump if a patient has hypoglycemia. You're going to treat the hypoglycemia and call endocrinology. The pump does have to be removed, and the infusion site's there, and it just clips in and out. It has to be removed if they're going to x-ray or any kind of procedure, because it's a computer, you can ruin it. And this is all of these things are in the nursing communication if you have a pump patient, and there's a lot. Has anybody ever had a pump patient? Yeah, do you see all the communications that are out there? Tons of things. So, all right, so glycemic control, for us, we're going to either use insulin in the house or they can use an insulin pump, okay? Some people, we occasionally run into diabetics who are well controlled here just on putting them on a good diet. So, and they haven't needed anything. But the reason we're working so much on controlling blood sugars is it does impact mortality. If we have people that we allow to have really high sugars, their mortality rate is going to be far greater than those that do not. And they've measured mortality rate even as far out as a year. And people that have better control in the hospital are going to have less, are going to not be affected with this mortality. And then it impacts the rate of infection. So people with high blood sugars, much more likely to get wound infections, urinary tract infections. They can have renal failure. They can have all kinds of complications from those higher numbers. I already told you it increases length of stay. What's one of the biggest differences between a diabetic and a non-diabetic? Glucose control. So it's going to increase length of stay, and all of these things result in an increased cost to the hospital. And with the way everybody's money is being managed, we sometimes could end up taking care of somebody the last day or two for free if we don't do a good job. So we want to do a good job in the hospital. It means basically the hospital can keep functioning. If you let people stay forever and ever because you never have good glucose control, not a good plan. So we do want you to use the glucose management tool, okay, which I showed you before. I would tell you, if you're on the computer today, to go out and pick a patient and look at the glucose management tool. If you want me to go in and show you right where it is, when I log out, I can do that. But this is the one-stop shop. It's the first thing I look at on every patient I'm consulted on is, what do their blood sugars look like? You know, what kind of insulin are they on? You know, what is their food intake? You know, if I see 9 here, I'm going to say, why did that person have 9 carbs, you know? So I can see everything. I can see if they had steroids and the effect the steroids had on the blood sugar. It's all right here for the taking. And again, this just shows you more about the glucose management tool. So I've been on the hypoglycemia bandwagon for about a year now. So I want to make sure you guys know what hypoglycemia is. Low blood sugar. It's, you know, you have too much available insulin and not enough food on board. So you gave that Humalog insulin, the patient didn't eat their food, you might anticipate that patient could have a low blood sugar. People that are renally compromised can have lows, elderly, you know, those people are much more prone, but we have lots of people that have lows here at the hospital. So the symptoms, shaky, sweaty, dizzy, headachy. And then we also have these people who aren't aware that they have a low blood sugar. We just go in and test. It's like, oh, your blood sugar is 57. And they say, I feel fine. And that does happen, especially people that have had diabetes for a long time. But hypoglycemia can lead to falls. So it's also a safety issue, besides the fact that people that have lows can have higher mortality rate as well. So we define a low as less than 70. And I've asked about this constantly. Point-of-care testing, if it's less than 70, is a low. On the lab does not consider a low until under 65. And the reason for that is because a lot of non-diabetics, if you don't have diabetes in the middle of the night, we do those morning blood sugars at 5 a.m., you may have a 65 or 68, and it's perfectly fine. may have a 62 and it's okay. But for a diabetic, anything less than 70 is considered a low. If you have a patient on insulin or treating, less than 70 is a low blood sugar. So, the treatment plan for these people with a low blood sugar, if they can take oral, they can drink. You're going to give them a half a cup of apple juice if it's less than 70. Once it's less than 50, it's a whole cup. And then what you're going to do is come back and recheck the blood sugar in 15 minutes, okay, to ensure that whatever treatment you did, and really, if you read the Ohio law, it says, you know, if you implemented a treatment, you should follow up to see how it worked. Just like with pain medicine, what do? You come back and say, you gave pain medicine, you come back and say, was the pain resolved, okay? Just like this, if you gave something to treat a low blood sugar, how are you going to tell it's resolved? We do not want to go by symptoms. You want to do another point of care. And it's recommended 15 minutes after treatment. If the patient cannot take oral juice, they're NPO, they're not conscious, they can't swallow, then we use IV glucose. You would actually push IV glucose through your IV. We are changing this a little bit in March when this comes out. Glucagon will be on there. We've had enough situations where people haven't had IV access on the rehab unit, psych unit, things like that. So we have added glucagon, which is injectable, IM injectable. People use it at home. Loved ones will have it at home for somebody that has a lot of lows. But and this will be expanded to say to you, document your hypoglycemia. So we have been on the bandwagon to get more people to document a low blood sugar and more nurses to follow up with that 15-minute repeat. We were not doing a good job of it. So in June, we started a whole new way for people to document a whole new thing. And Crystal actually got this BPA a few weeks ago, and it's a warning to all nurses. I don't think the students are going to get it, only nurses will get it. If a patient had a low, you're going to get this little warning, a pop-up that says, hey, your patient had a hypoglycemic event, go document, okay? So you would then, once the BPA fires, it's going to fire on any point of care less than 70. The documentation piece will fire in as a group for hypoglycemia under vital signs complex. And this just gives you a place to document. You don't have to do a handwritten note. Patient was shaky, sweaty, dizzy, headachy, I checked their blood sugar. I gave this, I did that. This is where you can just, it's a pick and click. Starting March 1st, the blood sugars will automatically populate. You won't have to document those. You're just going to pick what treatment you gave, what the symptoms were. Why do you think that patient had a low? Were they NPO? What was going on with that patient? And then did you notify the M&D? So we want you to use this. If your patient had one hypoglycemic event, this documentation, this flow sheet is automatically in their chart for the rest of the hospitalization. So if you ever go to document a blood pressure and you see, or a temperature and you see this flow sheet, you say to yourself, this patient already had a low, I need to be on high alert, they could have another, okay? So this is where you're going to document. You don't need to make a handwritten note. If you're given dextrose, certainly going to record that in the medication record, but you're still going to record it here. And again, this is somebody that had repeated lows, and they have 2 documentation records, one for each of the lows, okay? They had 56, it came to 64, that's still low. They put the 64 in, they're going to just keep populating, okay? So you want to document on all of them. Now, to that great glucose management tool, I was able to ask them to add in, if somebody had hypoglycemia, you'll see that right on that management tool, and you'll see what treatment they got. And you can hover on that, it's going to say 4 ounces of juice. So I can see that dip in the glucose management tool, I can see that low blood sugar, and I can see right away what the patient received. Again, another warning to the nurse, this patient had a low blood sugar, okay? So, what do Beth and I teach? Beth and I teach survival skills. It's kind of like what Joy Commission calls them. We know that people remember about 10% of what we tell them, so we try not to overwhelm them. If we're seeing a new diabetic, we're starting from square one. They absolutely have to know all about their medicines, how to eat, exercise, high and low blood sugar. They have to know how to check their blood sugars. They have to know what to do on a sick day, who to contact if they have an emergency, any kind of post discharge instructions, any kind of support things that might be available for them. So a newly diagnosed might take us quite some time if they're going to be new on insulin. If it's a patient that came in and they've had diabetes, many times we are looking for what are the barriers, why aren't they controlling their blood sugars, and we might go after one little nugget that we can change for them. Maybe they're not testing, or maybe they're still drinking pop. But we do a really good review with those people, and we really cover all of this, but it doesn't take us as long as a new diabetic unless they've just been doing nothing, or they had no education. We pretty much, everybody gets very individualized education. When I have students with me and they ask me, you know, what are you going to talk about when you go in there? It's like, I don't know, we'll see where the conversation leads us. Because you want that patient to kind of direct. You want to kind of gather information from them, find out where they are with things, and kind of let them direct where they need to be, what are the barriers. One of the biggest barriers is financial. And if it's financial, if they say, I know, and we can tell they do know, but they cannot afford to buy their insulin, they can't afford to buy testing supplies, they can't afford to buy the food they need, then that might be something Beth and I are working on. It's not so much education, but we're trying to solve the barriers. So we've already talked a little bit about new patients, but if you're the nurse taking care of that patient with newly diagnosed, Beth and I are here to support, but we're not here on the weekends. We aren't here all day with that patient like you are, so you should be aware, you know, if they have diabetes, if they're newly diagnosed, what is our plan right now, how are we adjusting things, have some conversations with the patient, you know, find out. If you're given insulin, you might say to them, oh, this is your rapid-acting insulin, you know, it lasts 4 hours, it works with meals. Then go to the patient education tab, take credit for it. If their tray comes and they're eating a sandwich, oh, did you know this bread can raise your blood sugar? It's a carbohydrate. Take credit for that. Oh, if you feel shaky, sweaty, dizzy, or headachy, let me know. It might mean your blood sugar dropped low. So these are all things as the nurse taking care of a patient. Beth and I see less than 3% of the inpatients here at Christ. Less than 3%. We see less than 3% of people with diabetes. Might be 3 right now. We're seeing a lot more, but we cannot cover the 23% of the hospitalized patients with diabetes. We have to depend on nursing to sort out who are the people we need to be seeing, okay? So sometimes the nurse will say to the physician they need diabetes education. Sometimes the physician recognizes it right away when they come in. We see everybody we can, and we prioritize. If we don't get to somebody, it's because we felt that they maybe didn't need us as much as somebody else. I would say rarely do we miss anybody. And then we want to have a current A1C. So sometimes we might go to the nurse and say, there's not an A1C in there, will you just go ahead and order them? Most nurses order them and don't worry about calling a physician. Occasionally somebody will call, but typically nurses feel comfortable doing that. So also more nursing role is like recognize those complications associated. You might have a patient in and they may be blind in their right eye from their diabetes. They may have an amputation. They may have neuropathy. And what do you think? If somebody had neuropathy and you were getting them up, what would should go through our mind? They could be a fall risk. They don't have good feeling in their feet. They could be a fall risk, okay? So while we don't think diabetes is saying, oh, if you have diabetes, you're a fall risk, these complications, blindness, low blood sugar, neuropathy, they can all lead to falls as well. And then you want to trend those blood sugars. You want to look to see how are their blood sugars look while they're here. I think every nurse should be looking at their patient's blood sugar control to see how they look and having that conversation with the physician to say, wow, their blood sugars are still 300, or they had a couple lows yesterday. Maybe the physician didn't see that and you're pointed it out to them. Does that patient have any educational deficits? Do they say, I've never tested my blood sugar, I don't know how to do that? Or, gee, I'd like to learn how to use insulin pens. What are the deficits those patients have? And I just told you about the barrier, and probably one of the biggest barriers is financial. People don't have money. It's gotten maybe a little better with Affordable Care Act, but even people that have insurance, good insurance, can't always afford their insulin. People who work at Christ Hospital are having trouble because it's expensive. People's co-pays could be $45 for each insulin and then $25 for testing. And then you start adding, $125 to your monthly budget, and it can be expensive. So sometimes Beth and I will have some tips to help them.